So these are the elderly, the diabetics, okay, immunocompromised, like patients with AIDS, your pregnant women, and patients with burn wound. Okay. So the fungi are being classified into two. They are either yeast or molds. Okay. So molds, you have your aspergillus, your dermatophytes, and your mucor species. While for your yeast, that is blastomyces, okay, candida, histoplasma, the coccidioides, and your cryptococcus. And then clinically, they can produce superficial mycosis or superficial fungal infections, and deep or systemic mycosis or fungal infections. Okay, so this is the structure of your fungal cell, and that is the cell membrane. Okay, so it's being zoomed out. These are the structures forming the cell membrane of your fungi. Okay, this is the yellow one, is your ergosterol. This is an important part of the cell membrane. It gives stability to the cell membrane of fungi. The drugs will be what? Targeting this ergosterol. Okay? The ergosterol synthesis pathway. There are two groups of drugs here. And then this your beta-1,3 glucan synthase, which is important in the formation of your beta-glucans. Okay? But what is important in your antifungal is the beta-1,3 glucan. Okay. Then other drugs will target the DNA or the RNA synthesis in fungal cells, preventing mitosis and division of fungal cells into daughter cells.
Doc, excuse po. Doc, gusto na sir ask me if we can turn off the lights here. Medyo ano daw po sa mata. Kaya dito lang po.
Gusto lang matulog.
Is it okay?
We don't have the that's the right. You book corrector की light check मार ली.
Let's see.
That's corrector sir.
One.
वो आएगी क्वेश्चन आएगी. इधर आंसर पड़ रहा है.
Can you see it now? Can you see it now? No.
Okay, so these are the different antifungals and their sites of action. Okay? So you have your terbinafine. This will prevent the conversion of your squalene to lanosterol. And then the azoles, this will prevent the conversion of your lanosterol to ergosterol. Okay? And then your flucytosine. Okay, so this will be blocking the formation of your purines, which you need for nucleic acid synthesis. And then the glycopholbin will be disrupting the microtubules, okay, the microtubulin assembly, so there will be inhibition of fungal mitosis. Then the polyenes, okay, these are your amphotericin B and your nystatin, okay, so they will bind with the ergosterol, so there will be formation of a pore or opening wherein the contents of the fungal cell will be extruded out and killing the fungi. Okay? So this is another, including the different drugs. So inhibition of ergosterol synthesis, the azoles, okay, and then your terbinafine and naftalin, okay, and then amphotericin B. This will be affecting the membrane function. Remember, there will be pore formation and a cell membrane. And then the caspofungin, this is for your cell wall synthesis. And that is your beta-1,3 glucan. And your 5-FU or 5-fluorocytosine, this will affect nucleic acid synthesis. Be sure you come back, huh? Do not believe yourself at home. Okay, so antifungals are classified based on their mechanism of action. Okay? So your caspofungin, fungal cell wall synthesis inhibition. So they are known as fungal cell wall synthesis inhibitors. Okay? Then your amphotericin B and nystatin, they are the ones that bind to the fungal cell membrane ergosterol, creating a pore. Okay? And then your terbinafine, naftifine, and butinafine. Okay, so this will inhibit the synthesis of your lanosterol, okay, which is part of the ergosterol synthesis. And then the azoles, they will inhibit the ergosterol synthesis. Those that inhibit nucleic acid synthesis, you have your 5-glucytosine, and those that cause disruption of the mitotic spindle and inhibition of fungal mitosis is your glycoprotein. Okay, the rest are miscellaneous ones. Okay. Now, based on structure, there are also another classification. So, actually, some of these antifungals are antibiotics. Okay. So these are your polyene, your amphotericin B, nystatin, and hamomycin. And some are heterocyclic benzofuran, like your glycoprotein. Okay. The antimetabolites, these are your glucytosine. And the azoles, you have two types of azoles, the imidazoles and the triazoles. Okay? Imidazoles are your ketoconazole, lotrimazole, oxyconazole, and miconazole. While your triazoles, okay, the newer ones, the newer azoles, these are your fluconazole, itraconazole, and voriconazole. Okay, the allyl amines, these are your terbinafine, butinafine, and the echinocandins, they all end in fungin. So, caspofungin, anidolafungin, and micafungin. And then other topical agents, you have your solnaftate, your anticyclinic acid, and your benzoic acid. Okay, so antifungal agents, they cause systemic infections and mucocutaneous infections. So for your systemic infections, what you can use are your amphotericin B, glucytosine, and azoles. And for your mucocutaneous, your nystatin, azoles, and allyl amines. Okay, so azoles can be used both for systemic infections and mucocutaneous fungal infections. Okay, first we have your amphotericin B. Okay, your amphotericin B has a broad spectrum of activity. Okay, so it is effective for this family, fungi family. Your Candida albicans, Streptococcus neoformans, endemic mycosis caused by your histoplasma, plastomyces, and their coccidioides. Okay, and then the pathologic molds, your aspergillus. You eat molds? Huh? Do you eat molds?
No. In blue cheese,
Yes. Very good for hot dessert. You eat molds.
Yes.
You eat mushroom. Mushroom are also fungi. Okay. We are amphotericin B. It is fungicidal. It can kill fungi. Okay? Fungicidal. And it is for life-threatening fungal infections. And it is usually used for initial induction regimen. Initial phase of management of severe fungal infections, like in patients who are immunocompromised or immunosuppressed, like patients with AIDS. For severe fungal pneumonia, severe cryptococcal meningitis, and disseminated endemic mycosis. Okay. So this is the coverage for your amphotericin B. They are effective for these different fungi family, okay? Aspergillus, your blastomyces, dermatitis, your candida albicans, Cryptococcus neoformans, your Toxidioides imitis, Histoplasma capsulatum, and the mucor species of fungi. Okay, for your blastomyces dermatitis, it has amphotericin has the broadest spectrum of action for this. While for your Toxidioides imitis, at high concentration, it is fungicidal and fungistatic at low concentration. Okay, it is also effective against your leishmania. Okay? So this is the graphic illustration of the mechanism of action of your amphotericin B. Okay, so it binds with your ergosterol. Okay, the binding is hydrophobically. Okay? Then they create a pore wherein, okay, this will happen. Potassium and other small molecules are lost through the pore, resulting to fungal cell death. Okay, resistance. Okay, the fungi have developed resistance to your amphotericin B, and this is the mechanism. The fungi were able to replace the ergosterol by other sterols in the fungal plasma membrane. Okay, always remember that the fight or battle between medicine and microbes are just like this. We discover new drugs, while the microbes, they also develop resistance by mutating or making some changes in their molecules. Okay? Just remember, you saw that in COVID. Okay? You are able to control the existing species of COVID, and then they develop mutation. So you have to fight again with another group or strain. Okay, for the kinetics of your amphotericin B, it is poorly absorbed when given orally, so it is given topically or intravenously. Okay, topically or intravenously. Okay. It is insoluble in water, so it is the colloidal suspension of amphotericin B. So it is available as suspension, and this is prepared with sodium deoxyfolate. Okay, in this ratio, 1:1. It is highly protein bound. Okay? 90% bound to plasma proteins. Metabolism is in the liver, and it is being slowly excreted through the kidneys in the urine. And then half-life is 15 days. Okay? It can cause minimal penetration into the CNS, vitreous humor, or amniotic fluid. Okay? Metabolism in the liver, and some are eliminated via the bile. And those that are eliminated in the urine, okay, remember, slowly excreted. So it will take about a long period of time. Okay, these are the different uses of your amphotericin B for life-threatening mycotic infections. So you don't use this just for skin fungal infections. Okay, life-threatening mycotic infections. For invasive aspergillosis, for rapidly progressive blastomycosis and coccidiomycosis, for your Cryptococcus neoformans, mucormycosis, disseminated rapidly progressing histoplasmosis, and it is reserved for resistant calaasal. And then it can also be used topically. Okay, adverse events of your amphotericin B. Okay, acute reactions, these are infusion related. Okay, so manifested by chills, fever, headache, pain all over the body, okay, nausea, vomiting, dyspnea, lasting for 2 to 5 hours, and this is all because of the release of your interleukin and your tumor necrosis factors. Treatment, slow down the infusion, okay, and give pre-medications like your antipyretics, antihistamines, hydrocortisone at a dose of 0.6 milligram per kilogram. Now, how about the long-term toxicity or cumulative adverse events? It can lead to nephrotoxicity, renal failure. Okay, so there will be azotemia, hypokalemia, acidosis, and decreased glomerular filtration rate. It can also cause anemia, and it can also be toxic to the CNS, especially if it is administered intrathecally. Okay, so manifested by headache, vomiting, and nerve palsies. Okay? It can also damage the liver, although it is rare. Okay, so this is your flucytosine. Okay? Flucytosine is, this will work better if there is amphotericin B. Okay, so amphotericin B will open the way for flucytosine. Okay, remember your amphotericin B, there will be a creation of a pore, so your flucytosine can enter the fungals there. And then it is, and then it is converted, okay, to 5-FU. You, by this enzyme, your cytosine deaminase, and then ultimately it will be converted to your DUMP, and this will be converted to DTMP through the action or help of this enzyme, thymidylate synthase. Okay? But this one will inhibit this enzyme. Okay? So if there is inhibition of this enzyme, then lesser DTMP will be formed, leading to inhibition of DNA synthesis and mitosis or cell division. Okay? So your flucytosine is water-soluble pyrimidine analog. Okay? It is, remember, there is an anti-cancer drug, okay, your 5-FU. But this 5-FU flucytosine is devoid of anti-cancer properties. Okay, it is available in oral formulation, and the dose is 100 to 150 milligram per kilogram per day. Spectrum of activity: okay, your coccidioids, neoformans, and chromoblastomycosis. So it's effective for this fungi. And look at this, it has a narrow therapeutic window. So what do you understand if a drug has a narrow therapeutic window?
Easy to overdose.
Huh?
Easy to overdose.
It's not safe. Okay? It is not safe. Not safe to use because of a narrow therapeutic window. There is, you could go into overdose easily. Okay, so adverse effects is bone marrow toxicity or bone marrow suppression. Okay? Because of this. And it is metabolized, okay? It is converted to your toxic anti-neoplastic fluorouracil. So that's why you can have bone marrow suppression. Okay? Okay, they are friends. flucytosine and amphotericin B. So they work together. Okay, this is synergism. Okay, 1 plus 1 was
3.
okay, more than 2. Okay, additive, it is 1 plus 1 equals 2. Okay, so in combination with amphotericin B, this is used in the treatment of cryptococcal meningitis. Again, it has a narrow spectrum of action. Okay? So not all fungi will be susceptible to your flucytosine. What is the advantage of combining your flucytosine and your amphotericin B? Okay, these are the advantages. Reduction in the toxic effects, okay? Rapid culture conversion, reduced duration of therapy, and decreased resistance. Okay, the azoles, okay, your imidazole, if it has 2 nitrogen atoms, and then triazole if it has 3 nitrogen atoms. What is that antibiotic which is an imidazole derivative? I think you are through with that. Antimicrobial. It also ends in azole. Your metronidazole. Okay? Okay, so your imidazoles can be used for topical. It has topical preparations and it has systemic preparations. While your triazole is only given for systemic fungal infections. Okay? So, topical ones, your butoconazole, clotrimazole, iconazole, oxyconazole, and your sulfonazole. While your ketoconazole and iconazole can be used for systemic fungal infections, both topical and systemic fungal infections. Okay, for your triazole, these are for systemic infections only. So you have your fluconazole, itraconazole, and terconazole. And FIT. Look, F-I-T. Okay, the azoles, they have a broad spectrum of activity, okay, including the amphotericin-resistant organism. Okay, and it is relatively non-toxic. Okay, though the manifestations is in the GI tract. And it causes liver function abnormality, and it also affects your cytochrome P450 of humans. Okay? So remember that most of the drugs, majority of the drugs are being metabolized by your cytochrome P450 enzyme system. Okay, so this is the process or the series of events in the formation of your ergosterol, which is an important component of the cell membrane of fungi. Okay, so acetyl-CoA converted to your iscoline. Okay, this iscoline, conversion of iscoline to your lanosterol is catalyzed by the enzyme esqualene monooxidase. Okay? And this is being blocked by your allylamines, like your terbinafine. Okay? While your azoles, they will block this enzyme, the 14-alpha demethylase. This is cytochrome P450 related. Okay? So there will be no formation of your ergosterol. Okay, so if it will inhibit your enzyme, okay, your enzyme P450, what will happen? So drugs that are being metabolized by this enzyme will what? They will not be metabolized. Okay? So there will be accumulation of this drug. Okay, so ketoconazole is the first orally effective broad spectrum antifungal. Okay, it has a greater propensity to inhibit the mammalian cytochrome P450. That's why you have more side effects. And it is effective against your dermatophytosis, deep mycosis, and candidiasis. The kinetics, effective when taken orally, and it needs an acidic environment for it to be absorbed. Okay, so the gastric acid must be in the acidic environment, lower pH. It has a high protein binding, okay, and it is readily distributed, but it cannot pass through your blood-brain barrier. Metabolism in the liver, excreted in the bile. The half-life is 8 to 10 hours, and the dose is 200 milligrams once a day or twice a day. Okay, these are the adverse events. Okay, nausea, vomiting, anorexia, headache, paresthesia, and alopecia. Your ketoconazole can decrease synthesis of steroids, testosterone, and estrogens. Okay, so low estrogen will lead to gynecomastia, oligospermia, loss of libido, and impotence in males. While the decreased estrogen synthesis will lead to menstrual irregularities and amenorrhea in females. Okay, as we have said, they can damage the liver, so there is elevation of your liver enzymes, and it can cause hypersensitivity reaction manifested by rashes and itching. Okay, drug interactions. Okay, ketoconazole is not a friend with amphotericin B. Unlike what is the friend of amphotericin B, the previous one, your antifungal is that? Your flucytosine. Okay, ketoconazole is contraindicated in with amphotericin B. So you don't use these drugs together. Okay. As we have said, your ketoconazole will also inhibit the cytochrome P450 of mammals or to humans. Okay? So the drugs that will be metabolized by this enzyme will not be metabolized, so there will be increased serum concentration of these drugs. These are just examples of the drugs being metabolized by your cytochrome P450 enzyme system. Okay, uses of your ketoconazole. Okay, they are effective for dermatophytosis because they can able to concentrate in the stratum corneum. Okay, for monoidal vaginitis, it will take about 5 to 7 days of treatment. Okay, systemic mycosis, your blastomycosis, histoplasmosis, and coccidiomycosis. Okay, ketoconazole is less efficacious than amphotericin B, and it has a slower response to ketoconazole. Okay, there is decreased efficacy in immunocompromised patients and in meningitis. However, the toxicity is lower than your amphotericin B, but higher than triazoles. Okay? So the triazoles are actually discovered because of the problem with your imidazoles. And that is always what is happening in drug development. Okay? High dose can be used in high dose in Cushing syndrome, and it is used for topical fungal infections like your Tinea pedis, Tinea cruris, Tinea corporis, and your Tinea versicolor. Okay, next azole. These are now your your triazoles, okay, itraconazole. It is available as oral preparations and IV preparations. Okay, absorption of this orally can be increased by food and low gastric pH. Now, it also interacts with the liver enzyme, okay, but lesser than that of ketoconazole. Okay, the effectiveness is also limited by the reduced availability caused by your rifampicin, okay, rifamycin, rifampin, rifabutine. And then cyclodextrin is being added to itraconazole to enhance the solubility and bioavailability. Okay, it has also poor CNS penetration, and it is the drug of choice for histoplasma, blastomyces, and scoliosis. Was the one who left earlier able to come back? Okay, might be lost. Okay, fluconazole. Okay, it is available as oral and intravenous preparation. It is also water soluble and it can penetrate the CNS. Okay, it can pass through the blood-brain barrier. It has high oral bioavailability and lesser drug interactions. Okay, it has the least effect on hepatic microsomal enzymes. Okay, and look at this, it has the widest therapeutic index, safest. Okay, the drug of choice for cryptococcal meningitis, both for the treatment and for secondary prophylaxis of your cryptococcal meningitis, and it is widely used for mucocutaneous candidiasis. Okay, next is your voriconazole, also a triazole. Okay, oral and IV also. More than 90% bioavailability when given orally. Okay, and they are also inhibitors of the mammalian CYP3A4. Okay. So there should be a dose reduction of your cyclosporine, tacrolimus, and your HMG-CoA reductase. What are the HMG-CoA reductase inhibitors? Or drugs for lipidemia. Have you taken dyslipidemia? Not yet? So these are your statins. Okay? And then this is the antifungal that can cause visual disturbance in 30% of cases. Okay? Uses of voriconazole is just the same as that of itraconazole. And it has excellent activity against Candida species. And this is the drug of choice for invasive aspergillosis. Next is your posaconazole. Okay, so this is the newest triazole, and it is available only as a liquid oral preparation. Okay, it has a rapid tissue distribution. Okay, so it can attain a high tissue level with relative low blood level. Again, they are inhibitors of mammalian CYP3A4, like your voriconazole, but it has no visual changes. Okay, the visual changes is for voriconazole. Okay, it has the broadest spectrum of action, including your Candida and your Aspergillus. Okay, and it is the only azole which is effective for your zygomycosis and mucormycosis. And it is being used as a salvage therapy for invasive aspergillosis.
sites. It's not a controllers.
Wala.
Doc, just one question. Doc, is moniliasis synonymous with candidiasis?
Yes.
Okay.
Okay, so it is also being used as prophylaxis, okay, during induction chemotherapy for leukemia, bone marrow transplant, okay? So this is just the tabulated form of the pharmacologic properties of the systemic azoles, okay? Their water solubility is here, the absorption, whether they can reach the CSF or the central nervous system, the different half-lives, okay? How they are eliminated, hepatic for H and renal for R, and then the form, oral or IV, okay? Okay, echinocandids, these are your fungins, so they end in fungin, cascofungin, microfungin, and amidulafungin. Okay, they are only available as IV preparations, but they are well tolerated with minor GI side effects. So these are the newest class of antifungals. Okay, they have large cyclic peptide being linked to your LC and FA. Okay. So the mechanism of action is inhibition of beta-glucan cell wall synthesis. Remember, this is the enzyme, the beta-1,3-glucan synthase. Okay? So this is how it inhibits the beta-glucan cell wall synthesis. And these are the different uses of your echinocandids. For disseminated or mucocutaneous candidiasis, okay, empiric antifungal therapy during febrile neutropenia, and for your candida esophagitis. Okay, your terbinafine and griseofulvin. Okay, remember, this one is choline-tolanosterol is being blocked by your terbinafine, and your griseofulvin will affect your fungal cell wall mitosis. Okay, so this is a comparison of your griseofulvin and terbinafine. Griseofulvin is fungistatic, while your terbinafine is fungicidal. Okay, cidal, it can kill the fungi. Okay, systemic treatment of dermatophytosis. Okay, this is your dermatophytes, especially your onychomycosis, topical treatment. Okay, and it is available in your microcrystalline form, and this is also available as in oral form. So these are systemic, this is superficial dermatophytosis. Okay, the mechanism of action, they bind to keratin, protecting the skin from new infection. Okay, while your terbinafine inhibits your ergosterol biosynthesis, okay, particularly affecting the fungal squalene epoxidase. Adverse effects, allergic syndrome, Here, adverse effects are rare, but if ever they do occur, it is headache and GI tract disturbances. Okay, drug interaction, warfarin and lead. Well, this has no drug interaction has been reported up to date. Okay, mechanism of action, remember, it inhibits mitosis. So there will be no cell division. Okay? So glycopulvin interacts with your polymerized microtubules and disrupts the mitotic spindles, thus arresting fungal mitosis. Kinetics orally administered, okay, but the absorption is irregular. Okay? It is increased by fatty foods and microfine particles. And then they are concentrated in keratinized tissue, and it is metabolized in the liver and excreted in the urine with a half-life of 24 hours. Okay, glycopulvin production of metabolites. So your glycopulvin is an enzyme inducer. Okay, so drugs being metabolized by this enzyme will be what? There will be increased metabolism of these drugs. So lower serum concentration. So you need higher or lower dose?
Higher.
Higher dose. Okay. So these are the drugs with which it interacts, your warfarin and phenobarbital. Okay? And because of these problems of glycopulvin, it has been replaced by the newer antifungal medications like your itraconazole and terbinafine. But you should know that glycopulvin is an antifungal, and these are the problems with your glycopulvin. So though it's being used rarely, okay? But still, it will appear in questions. Okay, so this is a table. You have this in your book. It is just summary, okay, to help you remember your antifungals. Okay, nephrotoxicity. So it is your amphotericin B, which is nephrotoxic. Okay, so your topical antifungal therapy. These are the drugs that can be used topically. Okay, nystatin, so the topical azoles like your cotranazole and miconazole, and the topical allylamines, your terbinafine and naftifine. Okay, azoles that can cause visual problem is what? Azole that can cause visual problem is BV, visual V, which one? Huh? Which azole is responsible for visual disturbances? BV, so it is your voriconazole. Yeah, it is here, it causes visual disturbance. Okay? Echinocandins. Okay, for salvage therapy in aspergillosis. I think. Then your flucytosine, it can cause bone marrow suppression. And it is synergistic with amphotericin B. And which one? Antifungal is contraindicated with amphotericin B, your ketoconazole. Okay, we'll try to see this one.